So Randy, Riley, and I are presenting on Wolff-Hirschhorn syndrome. And this is named after the German and American geneticist that discovered the abnormality in the 1960s. It might also be referred to as 4P syndrome or monosomy 4P. And Pitt-Rogers-Dank syndrome was also recently included with the Wolff-Hirschhorn syndrome group, with research showing that it is a mild form of WHS. It's just a smaller deletion amount. And we are going to refer to Wolff-Hirschhorn syndrome more as WHS because it's easier to say. So we are looking at the short arm of chromosome 4, specifically in the band of 16.3. So it's referred to as 4P16.3 deletion. And WHS includes 2 critical regions and 4 genes that are responsible for different phenotypes. For example, LETM1 is the gene related to seizures. Now, MSX1 is not a gene specifying that someone has WHS, but it is the one they attribute to cleft lip and palate among WHS patients. So the larger the deletion, the more severe the characteristics are manifested. So the critical region plus the areas connected to it lead to severe neurobehavioral outcomes. Now, interestingly, when 4P16.3 is deleted, it causes WHS, but when it contains a mutation, it causes Huntington's chorea. So this is one of many things that are being discovered that are continuing to be found with further research. Well, most cases are de novo, but sometimes a parent has a balanced translocation of the gene, which passes to the child. A balanced translocation means that 2 areas on the chromosome are switched, but there isn't any genetic information that's lost. And it doesn't have any signs of health-related consequences. So out of all the WH cases as shown here, 55% are from deletions from 4P area on the chromosome. 40% are from unbalanced translocations, and the other 5% are from other causes. The 40% from unbalanced translocations, that means that there is 2 areas on the chromosome that are switched, but there's also a deletion of some of the genetic information. So half of that 40% are inherited from a parent with a balanced translocation. So they have balanced and then they pass an unbalanced transition or translocation onto their child. The differential diagnosis is made by looking at all the characteristics that the child has. There are other syndromes that have similar characteristics, such as trisomy 13, Down syndrome, Angelman syndrome, Williams syndrome, and some others. So you look at all of that, and the diagnosis is confirmed by a cytogenetic analysis, specifically with a microarray that is sensitive enough to detect all the deletions in the WHS critical region. So if a parent is known to be a carrier, they can do prenatal testing on the fetus, which will tell you which genes are deleted and what the phenotypes are going to be. So when diagnosed, they recommend testing in all areas, regardless if they have signs or not, because some of the abnormalities are missed. So they want to make sure full testing is done. So it's thought that the prevalence is 1 in 50,000, but more research has suggested that due to misdiagnosis, it's more like 1 in 20,000. It's twice as common in females and males. And I couldn't find more recent numbers, but in 2003, there were thought to be at least 500 cases in the US. Now, WHS causes problems with muscles and development. Characteristically, you see hypotonia, underdeveloped muscles, and short stature. And due to the muscular abnormalities, the developmental milestones are delayed, like sitting, standing, and walking. Neurologically, absent seizures are common, but are often overlooked. So this kind of seizure is a brief, sudden loss of consciousness, which is more like blank staring or zoning out. So overall, these characteristics vary among all cases, depending on which genes are deleted, but all cases show growth deficiencies.
So because of these growth deficiencies, we're also going to see some craniofacial and skeletal anomalies. And there are some common ones that are associated with WHS. As you can see in this picture here, This child has microcephaly and micronathia. Her eyes are widely spaced and prominent. She's got big old blue eyes, and her nasal tip is broad, and she has a short philtrum with downturned corners of her mouth. You can't see her ears in this picture, but with individuals with WHS, we see low set ears with ear tags. The two most common skeletal anomalies include scoliosis and kyphosis. Kyphosis is a curvature of the spine measuring 50 degrees or greater, whereas scoliosis is a sideways curve of the spine. To put it into perspective, with kyphosis, which is 50 degrees or greater, a 25 to 40 degree curve in the upper spine is considered normal. So this is pretty severe. Studies have found that 15% of individuals with WHS will have sensory neural hearing loss. And this has to do with the delayed growth and development. So this hearing loss is in the cochlea. And a study by Ahmed et al. Was performed with mice with WHS, and it found that the hearing loss is caused by the cellular organization of the hair cells in the cochlea, and the innervation are defective due to their hindered development. So what we're seeing is that the number of hair cells is the same, but they're disorganized, and sometimes there's extra rows of the hair cells as well. So when we look at respiratory issues, including the heart, lungs, and trachea, we're seeing that there's a really high mortality rate, which is 30% within the first 2 years of life. The most common causes of death are respiratory tract infections and congenital heart disease or cardiac failure. In addition, there's an abnormal airway in these individuals, and that can lead to difficulty with intubation. And the heart defects are going to be the most common in individuals with WHS who have large deletions.
Speech and language characteristics of individuals with Wolff-Hirschhorn syndrome will vary. So as suggested earlier in our presentation, the size of deletion might correlate with cognition, language, and communication, but researchers have suggested that larger studies with more specific testing is needed to confirm these results. So in terms of communicative profile, so a study by Marshall in 2010 looked at over 200 individuals with 4P syndromes, including Wolff-Hirschhorn syndrome. And this study split up the participants by age, gender, and diagnosis, and administered the receptive, expressive, emergent language scales, or the REAL, and the MacArthur Communicative Developmental Inventories in order to get a big picture of what these individuals' communicative profiles look like. And what they found was that the majority of individuals with Wolff-Hirschhorn syndrome were below the 36-month level of language development. However, a small group of them were able to use more advanced language forms. So this includes putting 2 to 3 symbol sentences together all the way through conversational discourse and reading and writing. These individuals that had these more complex language forms were both verbal language communicators and also used AAC systems. So what this suggests is that in individuals in Wolff-Hirschhorn syndrome, expressive language development is likely to be very slow. However, the communicative profile of these individuals should not be underestimated, and they should be therapeutically addressed. So the authors of the study really suggested to presume competence in these individuals and not just assume that the language characteristics of these individuals is a homogeneous population. Another study by NAG that looked at the Vineland Adaptive Behavioral Skills found that social skills or socialization was an overall strength for these individuals compared to physical skills, life skills, and communication skills. Similar to speech and language characteristics, the cognitive levels of these individuals is also going to vary. However, a kind of a hallmark characteristic of this population is that they are all going to have a global developmental delay. So in the study I mentioned previously by NAG that looked at the VABS or the Vineland Adaptive Behavior Scale, They assess these individuals in terms of their daily living skills, socialization, motor skills, and communication. And they found that overall, all of the individuals with Wolf-Hirschhorn syndrome are globally developmentally delayed, with the exception, well, globally delayed in all domains, with socialization being a higher level of domain for them. But to give some quantitative measures, their mean adaptive behavior composite scale was 39 with a range of 20 to 65. So similar to communication, the level of severity can range, but all individuals are cognitively affected. All individuals with Wolf-Hirschhorn syndrome are also at a greater risk for dysphagia, and this is due to a couple different reasons. So first, we know that cleft lip and palate is seen in about 1/3 of patients with Wolf-Hirschhorn syndrome. And from what we've learned in our class this semester, we know that this can cause a variety of different feeding difficulties. However, for the individuals with WHS that don't have cleft lip and palate, we're still seeing difficulty sucking, poorly coordinated swallow, and GERD. So what this results in for especially young babies and children is often failure to thrive. So feeding intervention is usually warranted and very necessary. We also know that individuals with WHS have marked growth delays in both weight and height. And despite adequate calorie intake and feeding interventions, they are still remaining in the second percentile for length and weight between birth to 4 years. And because of this, tube feeding is often utilized at some point within the individual's lifespan.
It takes a village to ensure these individuals and their families affected by WHS have the best care and the support that they need. So there are lots of professionals who contribute to this care. When a family suspects their child has WHS, it's important that they receive a thorough evaluation by a neurologist, cardiologist, ophthalmologist, nephrologist, audiologist, an SLP, and if they have cleft palate, they may need a cleft palate team. So that is quite a lengthy list of professionals that they need to see. But again, we just want to make sure these children affected by WHS are getting the care they need to be successful, to grow and stay as healthy as they can. An evaluation with a geneticist is also crucial because they're professionals that can conduct testing, and they are the ones who can confirm the WHS. And throughout this person's lifespan, different therapies will be deemed as more important than others. So patients might be seeing an SLP, OT, and PT throughout their childhood and continue to seek out whatever is beneficial to their functioning through adulthood. And it's important that rehabilitative therapies are tailored to the individual's needs, because we know that every individual is going to be different and they're going to need help in different areas. So we want to be mindful of that and be paying attention to what other professionals are suggesting, but also what the parents are saying at home.
All right, that's it. Thank you for listening to our presentation. Here are our references. Goodbye.